Welcome, ladies and gentlemen, to one of the highlight sessions of the second day of Rio. And my name is Julian Chun, Frankfurt, Germany. I am very proud and feel privileged to welcome as the first speaker from Sweden, from Uppsala, Professor Carina Blomqvist Lundqvist. And she will present on a very important topic, AFib ablation as a first-line therapy. And what do the recent trial will tell us. So I'm very much looking forward to your presentation. And the next presentation will address another, I think, very important clinical question. And we encounter this clinical question more and more in our daily lives. And therefore, I'm very happy that Matthias Duchever from Belgium, Bruges, will report on AF ablation strategies for redo ablation patients with isolated pulmonary veins.
Hello, it will be a pleasure to talk about AF ablation as first-line therapy. Let's look at the very recent ESC guidelines showing that class 1 indication we have for AF ablation after a failed trial with antiarrhythmic therapy for both paroxysmal and persistent AF, whereas for first-line therapy, we have a class 2A indication for paroxysmal and a class 2B indication for patients with persistent AF and without major risk factors. So what are the trials? We have 13 randomized trials comparing AF ablation versus antiarrhythmic drugs, and 3 of them have compared AF ablation with drugs as a first-line therapy. So let's look into these first 3 trials that the ESC guidelines were based on. The first one was published in 2005 and included 70 patients, a small trial. Patients were monitored by 24-hour Holter monitoring, event recorder, and followed for 12 months. Primary endpoint, survival-free from AF, showed that the procedure was in favor for AF ablation as compared to antiarrhythmic drugs. We could also see that quality of life was improved significantly more in the PVI group as compared to the antiarrhythmic group. And the hospitalization was reduced more in the PVI versus the antiarrhythmic drug group. The second trial is a bit larger, 127 patients, randomized to ablation, RF ablation versus drug, monitored by Holter and TTM, followed for 24 months. Primary endpoint, recurrence of any atrial tachycardia, was superior for AF ablation as compared to drugs, with a recurrence rate of 54% as compared to 72%. Quality of life improved in both groups, but was not significantly different between the groups, so no difference. Now, if we look into the third trial, the MANTA-PAF trial, which was larger, almost 300 patients. Primary endpoint was cumulative AF burden assessed by 7-day Holters respectively. They were followed for 24 months. Cumulative AF burden was, however, not significantly different in the AF ablation group versus the drug group, 13 versus 19%, nor at the 3, 6, 12, or 18 months. But it was lower for ablation at 24 months follow-up. Quality of life was more improved in the ablation group with regard to the physical component. And we could also see that the quality of life was, however, not different between the groups at the 5 years follow-up, but at that time we could see that the cumulative AF burden was indeed significantly lower in the RF ablation group as compared to the antiarrhythmic drug group. So, that is the basis for the present ESC recommendation, and also the meta-analysis of these 3 trials show that AF ablation was superior to antiarrhythmic drugs, but did not reach statistical significance for symptomatic AF recurrence. And if we look at the safety aspects, there was 1 procedure-related death related to stroke in the ablation group and 7 tamponites. And in the drug group, we had a significant number of bradycardias. So RF ablation was more effective, but as shown, could cause quite severe adverse effect than antiarrhythmic drug. So it could be supportive for a first-line therapy in selected patients. Now, if we, I think we should go and look for other trials. There are new trials, 3 new trials that we will go through, and we will analyze them. And the new trials, the first one published is the early AF trial, including over 300 patients. They were quite healthy without any structural heart disease. And the primary endpoint was freedom from recurrence of atrial tachyarrhythmia at 12 months, was in favor of AF ablation as compared to antiarrhythmic drugs. In that early AF trial, we could also see that the quality of life was more improved in the ablation group and symptoms were less in the ablation group. AF burden was also lower in the ablation group as compared to the drug group. And if we look at the secondary healthcare utilization, there was in favor of the AF ablation. And if we look at the safety endpoint, they were in favor in the AF ablation group. And all 3 phrenic nerve pulses resolved within 1 month in the ablation group. And there were no PV stenosis and no fistula. So a safe procedure according to this study. The second trial is the STOP AF First trial, including over 200 patients monitored by TTM weekly and 24-hour haltering, pretty healthy patient group. Primary efficacy endpoint was treatment success, defined as freedom from initial failure or procedure or atrial arrhythmia recurrence at 12 months, again in favor of ablation as compared to the antiarrhythmic drug group. In this trial, there was no significant difference with regard to the healthcare utilization or cardioversion. Quality of life was significantly improved in the ablation arm, but was not compared with the antiarrhythmic drug arm. There was a high safety with 14% complication rate in the antiarrhythmic drugs and the ablation group. We could see the other trial from not yet published from Hermida, over 200 patients included, pretty healthy patient group again. And the results show that freedom from atrial arrhythmia was in favor of ablation as compared to the drug. Time to first serious adverse event, no difference, and very few complications in the ablation group. Safety is of great concern, and this is data from the German large registry of over 21,000 patients, showing that cryoballoon ablation has a low risk for tamponade, less than 0.5%, and not dependent on operator skill as compared to the RF ablation. We can also see from other registry, the European AF ablation registry, the frequency of phrenic nerve palsy has dramatically decreased during the past years and is now less than 1% for cryoballoon AF ablation. And given the very high safety of the procedure, which is emphasized in the recent AF guidelines to discuss with the patient. I think that given the knowledge that the hospitalization rate, which has increased over 300% during the past 20 years, and the knowledge that each additional year between AF diagnosis and ablation procedure is associated with an increased risk for a repeat ablation due to the AF progression, I think and hope that we will change the recommendation to translate the Class 2A into a Class 1 indication for AF ablation as first-line therapy. And my conclusion will be that cryoballoon PVI is safe, more effective than antiarrhythmic drug in improving quality of life and reducing hospitalization and AF recurrences. And it's time to recommend PVI as first-line therapy to improve the quality of life in patients with paroxysmal AF, and of course to discuss the patient preference. That is important. But we need, of course, randomized trial to confirm that the same efficacy and safety is the case in patients with persistent AF. Thank you for your attention.
Yeah, thank you very much for this excellent overview of regarding the most recent, very important trials in answering or investigating this question. And actually, this is the question I wanted to ask you, since you are or have been member of the ESC guideline writing committee. So when can we expect the next version update? Compromising and including the most recent trials. And would your recommendation be specific for an anatomic device, or would it be more general? What do you guess, or what are your feelings about this?
Well, my reply would be as an individual cardiologist, because I'm not in the position to decide when the next ESC guidelines will be issued. I wish that we could have sort of quicker update of the guidelines. We have now 3 randomized trials published just after the release of the guidelines, and if we're going to wait 4 more years, I think it would be a pity. So I couldn't answer your first question. With regard to the second question, I think that safety is very important. So given the result of these trials, well, one is not yet published, I think that we should go for the cryoballoon, given the fact that we have a much lower rate of tamponade, and we've seen that it's not operator dependent. And we have a very high efficacy, and we have also shown that it improves quality of life. Now, with PFA, I think that will be the future decision. Whether we should use that energy form, we cannot know until a year or 2 in the future.
Yeah, thank you very much. And again, thanks for the beautiful summary of the recent trials. And we now will switch over to the next presentation. It's going to be, as I said, Matthias Duchever from Belgium, and he will now answer or discuss with all of us the questions if a patient comes back, despite of an index ablation, and now all veins are isolated, what to do. So Matthias, I'm really looking forward to your thoughts.
Good evening, everybody. Happy to share my thoughts on AF strategies for radioablation in patients with isolated veins. And let's be honest, it is thoughts and not big data. I want to discuss the definition of 4 isolated veins, the likelihood of finding 4 isolated veins, and the strategies. The definition, for me, it is important to repeat that to define 4 isolated veins, you need a detailed repeat study with lasso at different positions, high-density mapping, and pacing maneuvers. So it is not a very easy diagnosis, and it is required that you have experience in this matter. The likelihood of finding 4 isolated veins has increased. We have data from protocol mandated repeats showing that starting from a RF and cryoballoon and now going to electroporation or temperature-controlled high current radiofrequency, that the likelihood of finding 4 isolated veins is as high as 80 to 90%. However, this is data from protocol-mandated 3-month repeat studies. In real life, the likelihood of finding 4 isolated veins is much lower, and in fire and ice, it was reported to be 20% for radiofrequency ablation and 20% for cryoballoon. However, developing a new closed protocol with contiguous ablations, we have shown that the likelihood of finding 4 isolated veins at the time of repeat for recurrence is now 62%. And we are not alone in showing these higher numbers of durability. Compared to fire and ice, likelihood has increased by 2 to 3-fold, and this is now based on many studies using contiguous ablations like the VISTAC study, the Sandorfi study, the ANTER study, but also after cryoballoon with optimized lesion delivery, the likelihood is now more than 60%. So yes, we are going to have good news. More durability means better outcome, like we showed with the REVEAL monitoring study, the close to cure, and with the multi-center study, the VISTAC study. However, the good news is followed by the bad news, which is that our dream has become the nightmare. We are now seeing patients with 4 isolated veins at the time of recurrence in the majority of cases. And you cannot predict those patients from looking at the clinical characteristics. Patients with 4 isolated veins, which is plotted in the lower panel, show the same time to recurrence. So it is not that they are having a different clinical profile. So it is a daily conundrum to make a decision in those patients with 4 isolated veins, what to do in those patients. And my thoughts are the following. And it's the same as with persistent atrial fibrillation. You can either choose patient-specific ablation strategies, or you can opt for fixed lesion sets. And there are lots of things you can do, but remember, in durable isolation, we have no data, let alone no randomized data. A typical mapping and ablation of patient-specific targets is the mapping and ablation of non-PV triggers. The eliciting of triggers is written and is described in many papers where you map and ablate the focus of a PAC, either spontaneous or by isoproterenol, or by inducing and terminating atrial fibrillation. The question and the challenge is, do we see the PACs in our lab? And the answer is no, not often. And if you see the PACs or the runs, can you exactly map the origin of these triggers? Besides that, there is the limitation of catheter-induced ectopy. One nice example of a patient presenting with runs, 4 isolated veins depicted in gray, and the patients had runs of atrial ectopies from the roof near the left posterior antrum. So this is a nice example how it could work, but in reality, it doesn't work always. Mapping and ablation of patient-specific low voltage is another patient-specific strategy. You have 4 isolated veins, you assess the area of low voltage, and you ablate that patient-specific area of low voltage. According to the paper by Hans Kootkamp, in 10 patients with durable isolation, low voltage is present in all of these patients, and ablation of this low voltage area leads to 90% freedom of atrial fibrillation. The advantage is it's a very objective endpoint, being the isolation within the encircled area. The disadvantage, however, it is rarely a straightforward scar. What is the cutoff you're going to use for voltage? How are you going to ablate? And show us some bigger data. So we do not know whether this could work. And I give you one example that immediately shows my concerns, which is the low sensitivity and specificity of scar to identify a potential region of trigger. Here is a patient. The patient had 4 isolated veins after close guided isolation. There is low voltage uniformly distributed around the left atrium. By chance, the patient triggered, and clearly the atrial fibrillation was originating from the superior caval vein, which showed normal voltage. This case shows that low voltage has not the sensitivity, neither the specificity, to identify the site of trigger, at least in this patient. So maybe patient-specific ablation is intellectually very appealing but difficult to achieve. What about fixed lesion sets? Just like we ablate pulmonary vein isolation for paroxysmal atrial fibrillation. One candidate for sure is empirical box isolation of the posterior wall. This dome of the left atrium is embryologically related to a possible arrhythmogenic focus. And the endpoint for the procedure is pretty straightforward. You isolate the box at the posterior wall of the left atrium. So the advantage is an objective endpoint, but the disadvantage, however, is that it sometimes is challenging, that the esophagus is interlaying between the ablation and the esophagus, and it is still a hypothesis-driven strategy. We have no big data in durable isolation. Only in persistent atrial fibrillation there are some data. Another option for empirical anatomical ablation is empirical ethanolization of the vein of Marshall. It's a strategy we are now performing on almost a daily basis in our cath lab, according to the results from Valderrabana and from Bordeaux. And what you can see is if you do ethanolization, is that you create a low voltage region, not only at the posterior wall, but maybe also or often at the ridge, which is a possibly arrhythmogenic focus. So the advantage is it leads to rapid voltage abatement and it might work. However, the disadvantage, challenging cannulation, still a hypothesis-driven strategy, and possibly a potential overshoot if you opt for this anatomical approach. What do we do in this point in time? We have a strategy where we encircle the veins in a wider circle when we see 4 isolated veins, and we isolate the SVC. This is our approach. Why the SVC? Why the posterior wall? Because in many studies, the posterior wall and the SVC are part of the triggers. And we do not believe that many studies show that the left atrial appendage is the trigger. So that is what we do. We make the circle wider and we isolate the SVC. Straightforward, wider isolation, SVC isolation. In this patient who had durable isolation after the first procedure, the patient was free of atrial fibrillation after the repeat. So it worked in this patient. Let's be honest, a second patient, a patient who underwent close-guided PVI, durable isolation of the 4 veins, no trigger isopretoranol, repeat strategy, we make the circle wider, we isolate the SVC. Does it work? No, the patient has atrial fibrillation. We published our results in the Jackie P paper by Jan de Poter and showed that if you treat patients with a wider circle and with electrical isolation of the SVC, you have a 60% likelihood of being free of atrial fibrillation at 1 year. It's not optimal, and it's certainly not as good as classical re-isolation of reconnected veins, but it's a starting point. And it could be part of a randomized trial. And this is exactly what we're doing. We are randomizing our patients and comparing widening of the circle and SVC isolation versus the same strategy with ethanolization. In conclusion, my thoughts. The diagnosis of 4 isolated veins requires a comprehensive study. The likelihood of finding 4 isolated veins has increased by 2 to 3-fold. Patients presenting with 4 isolated veins have no distinct clinical characteristics with similar time to ATAC recurrence. And at this point in time, it is unclear which redo ablation strategy is superior and whether the strategy should be directed at patient-specific targets or empirical fixed lesion sets. I thank you for your attention.
Wow, yeah, super. Thank you very much. I share many of your thoughts also about, of course, the beauty of eliminating the only trigger and then everything is fine. But this strategy obviously is pretty difficult to reproduce as a general strategy for, let's say, many, many labs in the world. So if I understand you correctly, you go like you add in a redo procedure with all veins isolated. Now you do a randomized trial, but in principle, SVC isolation, and not only in Asian patients, posterior wall ablation with what endpoint isolation, or do you just go there and ablate every potential? And the last, and this is my key question for your strategy, if you and we know that a wide circle is in theory better than a small circle. Why don't you do it in the first line?
Yeah, well, let me start with the last part. There is no study in the world, Yonggi, that showed that a large circle is better than a small circle. We and you are doing the same close protocol at the LEPV junction, and it's the most effective strategy for treating paroxysmal AF. And even in persistent atrial fibrillation, there is no single study showing that the large circle is superior. So the only thing we do is in patients with durable isolation, we have as an endpoint that we widen the circle and everything within the new circle should be isolated. So it is easy to isolate again on a larger extent. So the endpoint is pretty straightforward. The SVC isolation, yes, we do. It's straightforward. It is safe. It takes 8 minutes. Like I said, we are randomizing at this point compared to this strategy with ethanolization. But I don't want to claim that this is the strategy. I know that you are working on a randomized trial where left atrial appendage isolation is compared to voltage guided ablation. We need more of these studies. These studies should not claim that they know what is superior, but they should come up with new numbers that can help us in the next years how to treat those patients.
Yeah. Thank you very much. There's just a comment. I think there's an older study proving what is a proof in clinical medicine still. I think there's a study from the Thomas Ahrens group comparing larger versus smaller circles, and they could demonstrate a benefit.
But no, that's not true, Julian. That's not true. That study is called large isolation versus small isolation, but it's only showing circumferential ablation versus segmental. And nobody's referring that paper in the proper way. So we should read that paper over and over. There is good room for a randomized study. We can do it, big circle versus small circle. We can do it together, and I think we will be surprised about the outcome in paroxysmal AF at least.
Yeah, but this wider circle is bigger than this segmental approach. But yeah, the bigger, the better. From Brussels, I take that. And I'm looking forward to the randomized data. And I fully agree. We need studies addressing this topic because this is the more and more patients will show up exactly with that clinical scenario. All right. So, ladies and gentlemen, dear Karina, dear Matthias, thanks again for these excellent presentations. And I want to, and then have to unfortunately conclude this session. Thanks again, and I wish you all the best. See you soon.
Thank you. Bye-bye.
Bye-bye.
Hello, everybody. Good evening again from Frankfurt. It's my greatest pleasure to summarize and wrap up the second day of Rio Rhythm Interventions Online. I think it's a beautiful program today with a great faculty. We had extremely interesting live sessions and presentations and discussions. The first session did cover the topic of VT ablation and the background, the data, which drives us to perform VT ablations. We also had an outlook looking into the current practice, but also the future in the field and the growing field still of AFib ablation. I think that the second session with the live case from Milano performed by Paolo Della Bella was very exciting, great faculty, great discussions. And unfortunately, we had to leave Paolo with a running VT in the end. I hope he managed, and I'm sure he managed the case very well. The third session was covering an also very interesting topic, convergent ablation, which means combining operation, posterior wall ablation in the OR in combination with an EP procedure and potentially filling in gaps, etc. And we saw beautiful pictures, and we had a very good discussion with the live case from London performed by John Jab and Said Azan. In the fourth session, we again went back to Germany, and from the Heart Centre in Leipzig, Arash Aria and his team showed us a very challenging case with a left atrial macroreaction tachycardia. And I have seen they addressed linear lesions, but I could not realize if they made it to terminate during the live case, but I'm sure they terminated right after setting the proper lesions. But the discussion was also very good. In the last session, which I had the privilege to chair right now, did deal with burning questions regarding the time point of AF ablation and the best strategy in permanent PV isolation. So in the end, I think it was a tremendous, it was a fantastic and exciting day. I did enjoy it a lot, and I'm very much looking forward to tomorrow. Tomorrow, tune in again, 4 o'clock Central European time, and we will focus on all news in the field of devices. And I'm really looking forward to see you tomorrow again. And until now, we had more than 2,000 participants attending this Rio intervention live sessions and presentations. And also one thing, go to the website and fill out the feedback poll, because we want to improve for the next year. Thank you very much. Have a great night.